Hi, I'm Micah Long. Today, I'll be talking about what we bring to the table for the patient in terms of our experience in an emergency intubation and what that means for the patient in terms of their risk. I'm a practicing critical care anesthesiologist, and I have many years now of experience intubating in the critically ill. I started getting involved in this as an early anesthesia and before anesthesia pediatrics resident because I was so scared of showing up to airways and codes on the floor and in the intensive care units that I went to as many as I could so I could get a few reps under my belt as a watcher or learner before I was required to be the one in the hot seat. And from those experiences, I put the talk together today. I want to tell you a story to start out. Maybe you want to close your eyes or maybe not. Right after I finished critical care fellowship and I was a young ICU faculty at my hospital, I was asked by a different faculty in the critical care unit to help with an intubation. Their patient was supramorbidly obese with a BMI in the low 60s, had end-stage liver disease, and acute kidney injury with acute renal failure, massively swollen and edematous, 4+ and above edema everywhere. They had maybe a GI bleed. They had maybe a gastric obstruction. They were vomiting on and off, completely altered with hyperammonemia, and their lungs were very unwell. The thought was they had evolving aspiration pneumonia. They were on 100% non-rebreather plus a high-flow nasal cannula under the non-rebreather, and their SAT was 86% with a respiratory rate above 40 or 45. I heard the story, knew I had to act quickly, grabbed my airway equipment and bag, rolled up to the room to get things situated as the nursing team and respiratory therapists were helping, and the medical team was trying to get the patient optimized and give medicines to fix their pneumonia and the like. As I went towards the head of the bed to do my final equipment setup and position the patient, a resident rolled in. It was an inexperienced resident. And as they got in the room, I see that they had brought their own airway equipment. And I looked at them and I said, "Hi, I'm Dr. Long. Who are you?" And they told me they were a resident and that they've done over 30 intubations, that this was their patient and that they wanted to do this intubation. And I looked at the patient who was audibly gurgling on the bed, and that was at 30, 40 degrees, head up. And I said, "I'm very sorry. I'm going to take this from you. I need to do this intubation myself, and I don't want to do it." This story highlighted the idea to me that it might be risky to let trainees take on some of these airways, but it made me feel horrible. The resident was despondent, very upset, and dejected a bit. They had committed their time and attention to that patient. They'd cared for them immensely, and I took away a learning experience from them that eventually they'll be responsible to do on their own. And I wondered, did I do the right thing or not? As I started researching this question, what you find out about intubation and critically ill is that the intubations are hard. They're hard because the space you work in is worse. Your equipment is farther away. It's positioned farther from you. The rooms are not set up to intubate, and neither are the beds. You have to take the head of the bed off and climb onto the metal structure. I sometimes have to put a pillow under my knees just to get close enough to the patient, who's always sliding down the bed. If I call for help is not always nearby. I might have to wait for somebody to run from the operating area, which in our hospital is probably 100 yards away. They're technically more challenging. They're not positioned well. They're less healthy patients who are more prone to be aspirating and have either very dry mouth or very spitty mouth. They might be edematous, have edematous airways, or have been recently intubated. In addition to these technical difficulties, they're physiologically difficult. These patients are neurologically unwell. They may be agitated. They may be aspirating and not protecting their airway. Their heart may be on the verge of failing or already collapsing, and their physiology of respiration is poor. They're hypoxic. They're working hard to breathe, and they simply don't tolerate hypercarbia, hypoxia, or apnea at all. It's pretty impossible to adequately pre-oxygenate a deteriorating ICU patient. And so while we do it and we do our best with it, and it's crucial to do, it's just not the same as intubating in the operating room environment. Reviews on this have supported this, showing that complications are drastically higher in ICU intubations or emergency intubations as opposed to elective intubations. And even in those patients you thought were hemodynamically well, they don't do well after you take away that anxiety and catecholamine drive they had before you gave induction medicines. Systematic reviews on this are consistent, and I gave a talk about this previously. About a quarter of patients get either severe hypotension or hypoxia or both. 1 in 50 have cardiac arrest. And what I find very interesting is that difficult airways are associated with these complications. Of course, unwell patients have, strings of unwell things happen, but they also lead to complications. Dividing your attention between a difficult procedural airway and a difficult physiologic decompensation of a patient is very hard to do. It's hard to know how to manage impending cardiac collapse in a pre-code while you're also struggling through whether you should grab an LMA bougie or just have the trauma surgeon do a tracheostomy. These are airways that go beyond your technical abilities. You need to know not only how to do the procedure, but how to do it very fast. You have to be fluent in all of your backup plans and know how to manage the cognitive burden of when to give up a procedure and move on to the next one, when to divide your attention and when to assign other people or call for help, and how to run the room well from a leadership perspective. Lots of things play into a successful intensive care unit intubation. So many things play a role in the success of the urgent and emergent intubation that it's no surprise that you need experience to do it well. Studies looking at anesthesiology, residents, and trainees are shown on the left, and what they show is that you improve your first pass success, which is a surrogate marker for how challenging or easy an airway is, and has been shown in a myriad of publications to correlate to outcomes in the patient, not only for things that are obvious like esophageal intubation and hypoxia, but also things like hypotension and collapse. Again, because if you're struggling with the airway and needing to take 2 or 3 attempts, you're not paying as much attention to the hemodynamics, or you're paying attention to hemodynamics and not able to get success on the second time because your attention is divided. First pass success rates evolve through anesthesia training. This is over hundreds of intubations, 65% first pass success VL or DL, PG 2-year, PG 375, and PG 485 with equal success in that group of DL to VL, a whole discussion in and of itself, but this is essentially taking your best people who have hundreds of intubations, they're still improving. Similar work has been shown in the European model, where critical care does a lot of anesthesiology training and success rate improving drastically over years of intubation. And similar work has been published in the emergency medicine community, where the intubation experience varies, but there's a drastic improvement over success over years of training. A group out at the University of Washington has shown that this matters, and it matters for patient outcomes. Inexperienced intubators who had done fewer intubations had worse hypoxia during the procedures. And when we look at those early studies I referenced looking at outcomes of intubation, what we find is that procedural hypoxia is associated with cardiovascular collapse. In that group, mortality is higher by a lot. And you're left faced with a simple fact. If inexperience is associated with hypoxia, and hypoxia is associated with collapse, and collapse is associated with death, trainees may be harming people. Major studies that look at how to predict difficult intubations, and in fact the ones that I showed earlier showing that difficult airways were associated with these important patient outcomes, have shown that non-anesthesiologists have more likelihood of experiencing difficult airways in these intubations. That makes sense as a proceduralist. The more you practice and do something regularly, routinely as part of your daily practice, the better you are at it. But it does support the idea that experts are simply not the same as non-experts. This isn't addressed adequately in the literature, I think because we try to be polite and kind to one another. And of course, there's outlier success stories, as in there are people that intubate 100 times and are wonderfully competent, more competent, in fact, than people that have intubated 1,000 times and everything in between. But when we look at studies that compare intubation done by people with an immense amount of experience, their complication rates are simply lower than studies that take fellows or residents performing these intubations in the urgent and emergent airways. And these are not subtle. They're important outcomes. Therefore, I argue that experts can prevent complications. Literature supports the idea that the best outcome for your patient is to use an expert operator. Now, thankfully, there is excellent work that looks at supervisory models or collegial models where, say, an anesthesia faculty attends emergency airways with anesthesia trainees, or an anesthesiology provider attends emergency intubations done by emergency medicine physicians who certainly are able to run a room and direct the physiology, but may have less procedural experience. And in those environments, those models are perfectly excellent and the best not only for the patient, but for the training and communication of everybody. This falls back on the idea that we can all read a lot of books about golf and go out a couple days and hit golf balls at the course, but teaching tips and techniques is simply not the same as going out and playing games of golf competitively every day of the week for many weeks and many years. So it isn't necessarily the field you're in, but it is how you train, the experience you bring, and how you've learned from those experiences. I, in fact, do a whole talk and lecture on how to speed up your learning curve. How can you maximize each individual procedure so that you're much faster at learning than the average person? But knowing that inexperience may hurt people, I've decided that there are several airways I simply cannot supervise. Those airways are those where first pass success is crucial. These are the swollen airways, inspiratory stridor, evolving anaphylaxis. When your first look may be your only look, and when the vascular airway may swell when you're shoving a blade in it, and it may swell to closure, those are not learning airways. I don't supervise airways where high speed is necessary. These are the messy, vomiting airways, varying stages of aspiration. And finally, I get concerned about dividing my attention. It doesn't mean I always steal the airway in the high-risk patient, but if they are truly a code or near code, and I am fearful I won't be able to divide my attention successfully between managing their immense hemodynamic burden to a difficult airway, then those are no longer learning intubations. And that includes things like severe hypoxia, which is also an argument for mandatory high speed, or ARDS with RV dysfunction. Those things pose a risk to patients, and I do not believe they should be done by anybody but the most experienced person in the room, because I believe that's what you'd want for your family, and it's definitely what I'd want for me and my family. Now, I'll end this by saying that it's crucial to avoid silos. I don't think only anesthesiologists should intubate. I think there's a lot that I can learn about the management of an immense number of things from an emergency medicine physician or another critical care physician, and from a whole host of other physicians and people that bring different skill sets to the table. That being said, we should all know the risks that we bring to patients when we aren't the best at something. I do chest tubes. I do them all the time. I do them routinely, but I simply don't do them as often or in high-risk, high-speed scenarios as an emergency medicine physician. The last time I had a tension pneumothorax in my ICU, I grabbed all the equipment, ran to the bedside while I had my team paging a colleague of mine who is an emergency medicine physician to help me because I knew they were faster than me and it was the right thing for the patient. And that's something I'm certainly qualified to do, that I've done hundreds of times, that I teach routinely. My intubation team during training was a CA3 resident, a fourth-year anesthesiology resident, plus a second-year anesthesiology resident. We had faculty that sometimes showed up, but by the time you're a PG4 resident physician in anesthesiology, we didn't think they added a lot, except that it helped us feel more comfortable, relaxed, and allowed a second person to manage hemodynamics while we managed evolving difficult airways. I manage my skill now as a faculty by taking airways from anybody I can steal them from anytime I can. It's important as we think through this talk that our more experienced in years faculty may not have maintained procedural experience in numbers. Maintenance of a skill set, of course, is much easier than progression of a skill set or early development of a skill set, but maintaining skill as a faculty is part and parcel to this entire discussion. It's important that our faculty participate in what I would call procedural CME. One question I get when I give this talk is how I think infrequent intubators, those that may graduate residency with under 200 intubations, should do airways, specifically with regards to DL and VL, or just one. And I'm going to answer that with a question. And it comes into maybe a little bit of your value system you bring to the table as a physician. If you are an emergency medicine physician, you may see some messy, bloody, or vomiting airways that occlude your video laryngoscope. That camera can get occluded, and if you've never done a DL before, you have to be quite mindful that your first time may be a messy, bloody catastrophe airway. That being said, if you're only going to get 80 to 100 airways, the DL learning curve takes 600 to 700 airways. You're never going to get there. It's been shown time and time again. So while you may develop competence, you will never develop expert level skill. So it may be better, if you're doing a limited number of intubations, to develop one skill that you can develop quite adequately and quite well, and focus on VL with immense amount of suction, like with a salad suction or a double suction setup, as I discuss in a prior talk on airway checklists. At any rate, that's all I have on intubation experience and patient risk. I wish you well, and I hope you a safe next intubation. Thank you.